Usually, when we talk about a medical diagnosis, there's a certain expectation of precision.
Oh, absolutely. Like, you want a clear answer.
Right. Like if you fracture your radius, you get an X-ray, it shows this jagged white line, and the doctor points right at it and says, there is your problem.
Yeah, it's a very comforting way to view disease. You cross this structural threshold, and boom, the diagnosis is definitive.
Exactly. Broken or not broken. But when you step into the world of blood pressure, that binary framework just completely shatters.
It really does. It falls apart.
Because we're looking at a diagnostic landscape that is entirely continuous, which honestly makes it remarkably difficult to pin down.
Yeah, it's a total moving target.
So welcome to this deep dive. Our mission today is to really investigate what is often called the silent pressure, basically the pathophysiology of hypertension.
And for you listening, we aren't just going to read off a standard medical glossary today.
No, definitely not. We want to decode the hidden interlocking biological systems inside your body that are actually driving that chronically high blood pressure.
And we have a really brilliant stack of sources to pull from to do this. We're looking at landmark epidemiological research, specifically the famous Framingham Heart Study.
A total classic.
Right. Alongside these pivotal clinical trials like SPRINT and Simplicity, HTN3, plus we're digging into some foundational physiological theories that fundamentally rewired how cardiologists even view the human vascular system.
Yeah, and by the time we wrap this up, you'll see why that standard, boring lifestyle advice you hear from your doctor, like eat differently, move more, it's not just generic wellness fluff.
Far from it.
It's actually highly targeted chemical warfare directed at very specific pathophysiological mechanisms. But to understand how this silent pressure harms us, we first have to ask kind of a deceptively difficult question.
Which is?
What actually counts as high blood pressure?
Yeah, right. And like I said, it is a moving target. Hypertension isn't a threshold disease like that fractured bone. It's a continuous risk gradient.
Right.
And watching the definition of what constitutes, a disease shift over the decades, it's a fascinating case study. It shows how medical policy evolves even when human biology hasn't changed one bit.
Yeah, the historical numbers we used to accept are honestly pretty staggering.
Oh, they're wild.
Based on the sources for a huge chunk of the 20th century. The medical consensus used this, informal rule of thumb for systolic pressure. It was 100+ year age.
Which is just crazy to think about now.
I know. So that meant a 70-year-old walking around with a systolic reading of 170 millimeters of mercury is just deemed, perfectly healthy.
Yeah. And a reading of 170 today. A modern cardiologist would be aggressively starting you on pharmacotherapy, immediately.
Right, but that old rule was just born out of, an incomplete understanding of hemodynamics. As the longitudinal data got better, the thresholds dropped.
Exactly. So by 2003, the U.S. Joint National Committee set the diagnostic line at 140/90.
Which held for a while.
It did, until the landscape shifted dramatically again in 2017. That's when the American College of Cardiology and the American Heart Association lowered the definition to 130/80.
Which creates this incredible paradox, right? When those guidelines dropped in 2017, tens of millions of people instantly acquired a chronic disease literally overnight.
Yep, just from a policy change.
Even though, their endothelial cells and their blood vessels were in the exact same state they were the day before, it really highlights that tension between biological reality and policymaking.
Right, because the pathology doesn't care about a nice round number like 130.
Not at all.
And that is the absolute crux of the diagnostic dilemma. Cardiovascular risk rises smoothly, exponentially, from very low baseline pressures.
There's no magical cliff where risk just drops to zero.
Exactly. So medical bodies are forced to basically carve this arbitrary statistical line through a continuous gradient just to give doctors a framework for treatment.
Which explains that weird geographic dissonance. You could be diagnosed as hypertensive in the U.S., but fly to a jurisdiction using European guidelines, and they'd tell you, hey, your pressure is fine.
Yeah, you're cured on the plane ride over.
Exactly. But before we get too deep into modern policy, I want to look at how we even figured out how to measure this invisible force. Because the early attempts were, quite frankly, brutal.
Highly, highly invasive. Yeah.
So where did this start?
Well, the origin points back to this English scientist and clergyman Stephen Hales back in 1733.
Okay.
He wanted to quantify the pressure directly, right? So he actually inserted a brass pipe into the carotid artery of a conscious horse.
Wait, a conscious horse?
Yeah.
A brass pipe? Oh my gosh.
Yeah, and the arterial pressure forced the blood 9 feet up a vertical glass tube.
That is, I mean, it's a mechanical breakthrough, sure,
Huh.
but obviously not a clinically viable tool for human patients at the doctor's office.
Yeah, oh, definitely not. You're not going to get many volunteers for that.
No. So
Yeah.
the shift to something we'd actually recognize didn't happen until 1896, right?
Oh.
When the Italian internist, Scipione Rivaracci, invented the inflatable cuff, the sphygmomanometer.
Try saying that 3 times fast. But yeah, the cuff was huge. But the real ingenuity was layered on top of that a few years later, in 1905, by Nikolai Korotkov.
He was a Russian military surgeon.
Right. And he realized that if you place a stethoscope over the brachial artery in the arm and slowly release the cuff's pressure, you can actually hear these distinct acoustic signals.
Which we still call Korotkov sounds today.
Exactly. So when the cuff pressure is higher than your systolic pressure, the artery is totally pinched off. Silence.
Makes sense. No flow.
But as the cuff deflates and falls just below that peak systolic force, blood suddenly jets through that narrowed space during every heartbeat. It creates turbulent flow.
And that turbulence makes a sound.
Yeah, it generates the snapping or tapping sound. That first snap, that's your systolic reading.
Okay, and then the diastolic.
Well, when the cuff deflates even further, the artery opens back up to its normal diameter. The flow goes from turbulent back to laminar, meaning smooth, and the sounds completely disappear.
Oh, so that exact moment of silence is the diastolic reading.
You got it. It's just a really elegant application of fluid dynamics.
It is. But, having the measurement didn't mean they immediately understood the pathology. Like, for decades, doctors actually thought elevated blood pressure in older adults was a good thing.
Yeah, they called it a necessary positive adaptation.
Right. The assumption was like, well, as peripheral arteries stiffen with age, the heart just has to pump harder to get enough blood up to the brain and the kidneys.
They were actually worried that lowering the pressure would cause organ ischemia, like starving the organs of oxygen.
Which is wild to think about now.
Yeah.
But that paradigm didn't shift until the Framingham Heart Study came along, right?
Exactly. Launched in 1948, Framingham tracked the cardiovascular health of thousands of, normal asymptomatic residents over decades.
And what did they find?
Well, by the 1960s, the epidemiological evidence completely dismantled that helpful compensation theory. Hypertension was revealed to be this independent, highly destructive, modifiable cause of cardiovascular death.
Yeah, the data showed that cardiovascular risk actually doubles for every 20-point rise in systolic pressure, or every 10-point rise in diastolic.
And that's starting from a baseline of just 115/75.
Wow. It's just so fascinating that a survival mechanism designed to adapt to the environment ends up locking us into a state of chronic disease.
And that's exactly where it earned the nickname the silent killer, because that structural damage just accumulates for years without any sensory feedback at all.
Right, you don't feel it.
Yeah.
So to understand how that structural damage actually happens, we need to move from epidemiology into the physiology of it all.
Let's do it.
And the sources frame this through a foundational equation in fluid mechanics.
Yeah.
Mean arterial pressure equals cardiac output multiplied by total peripheral resistance.
MAP equals CO times TPR.
Yeah. Let's map that onto something tactile for everyone listening.
Right.
Cardiac output, that's basically the volume and force of the water leaving a water pump.
Okay. Yeah.
And total peripheral resistance is the diameter of the garden hose carrying that water. So if someone steps on the hose, resistance goes up, and the pressure inside the hose spikes.
That's a great analogy. And in chronic essential hypertension, we are overwhelmingly dealing with a stepped-on hose problem.
Not a pump problem.
No, it is a peripheral resistance pathology. I mean, in the really early stages, you might see elevated cardiac output, but by the time hypertension is really entrenched, the heart's output is often normal or even lower than normal.
So the crisis is happening in the hoses.
Yes. Specifically, the arterioles. Those are the small muscular branches of the arteries. They become narrowed, stiffened, or just chronically constricted.
Okay, so the million-dollar question is, what biological levers are actually stepping on that hose?
Well, the sources point heavily to this chemical cascade called the renin-angiotensin-aldosterone system.
The RAAS pathway.
Exactly. And it all kicks off in the kidneys. When specialized cells in the kidneys sense a drop in pressure, they secrete an enzyme called renin into the bloodstream.
Right. And renin goes looking for something.
Yeah, it bumps into this protein from the liver called angiotensinogen. Renin basically chops it up and turns it into angiotensin theirs.
But angiotensin is relatively inactive, right? It doesn't do much on its own.
True. It's pretty harmless until it flows through the lungs, the pulmonary circulation.
Ah, the lungs.
Yep. In the lungs, an enzyme rapidly converts it into its active form. That's actually why it's called angiotensin-converting enzyme, or ACE.
Wait, ACE? Like an ACE inhibitor?
Exactly like that. We'll get to those later. But the result of that conversion is angiotensin II. And this stuff is one of the most potent vasoconstrictors in the human body.
Wow. So it just clamps down on the blood vessels.
Instantly. It binds to receptors on the smooth muscle of your blood vessels and forces them to constrict.
So there's our stepped-on hose. But the RAAS cascade does something else too, right? It has a dual mechanism.
It does. Angiotensin II also pokes the adrenal cortex to release a hormone called aldosterone.
Okay, and what does aldosterone do?
It travels right back to the kidneys and fundamentally alters how they filter things. It forces them to reabsorb sodium.
And because water always follows sodium osmotically, your overall blood volume expands.
Exactly. So now you have a simultaneously constricted hose and a larger volume of fluid being forced through it.
Which is a perfect recipe for high pressure. But this RAAS pathway, it doesn't just operate in a vacuum. It interacts heavily with the sympathetic nervous system, right? Our fight-or-flight network.
Heavily. In modern life, things like chronic psychological stress, sleep apnea, or metabolic syndrome, they keep our sympathetic tone constantly elevated.
Meaning we're always mildly in fight or flight.
Right. And sympathetic nerve terminals literally release norepinephrine directly onto the blood vessels, sustaining that tight constriction.
But you'd think our bodies would notice this, right? Like, don't we have internal sensors to detect when pressure gets dangerously high and, turn down the dial?
We do. They're called baroreceptors. They're these specialized stretch receptors in the carotid sinus and the aortic arch.
And they monitor pressure minute by minute.
They do, but here's the flaw. They are vulnerable to adaptation. It's this phenomenon known as baroreceptor resetting.
Resetting.
Yeah. When blood pressure stays high for a long enough time, these receptors actually adjust their firing thresholds. They recalibrate to accept the new higher pressure as the baseline normal.
Oh, wow. So the physiological alarm system just turns itself off.
Essentially, yeah. The central nervous system just stops trying to fight the hypertension.
That is wild. And that structural recalibration ties perfectly into the third mechanism, which involves Arthur Guyton's work in the late 20th century.
Right. Guyton was brilliant. He applied systems engineering principles to human physiology.
And he proved that over the long term, the kidney is basically the absolute dictator of blood pressure through something called pressure natriuresis.
Exactly. So normally, if your arterial pressure rises, a healthy kidney responds by rapidly excreting excess sodium and water.
Right, to lower the blood volume and bring pressure back down.
Right. But Guyton showed that in chronic hypertension, the kidney's function curve actually shifts. It develops this blunted response.
So it stops working as well.
Basically, it now requires an abnormally high perfusion pressure just to excrete a totally normal daily load of dietary sodium.
Let me make sure I've got this. To synthesize Guyton's theory, the body is willfully sacrificing safe vascular pressure just to maintain sodium homeostasis.
Yes. The kidney demands higher pressure to do its job, and the cardiovascular system just obliges.
So hypertension is, in many ways, just a kidney disease masquerading as a heart condition.
That is a very prevalent view in modern nephrology, yeah.
Wow. And the consequence of the kidney demanding that high pressure brings us to the final mechanism, the actual physical degradation of the vascular architecture.
Right, the pipes themselves start to break down.
Because the single-cell lining of your blood vessels, the endothelium, is responsible for secreting nitric oxide, right?
Yes, and nitric oxide is this crucial signaling molecule that tells the vessels to relax and dilate.
But all that mechanical shear stress from the high-pressure blood flow mixed with metabolic inflammation, it causes endothelial dysfunction. So nitric oxide plummets.
Exactly. And because the heart is constantly pushing against that heavy resistance, the smooth muscle in the arterial walls starts to physically remodel. It gets thicker. Hypertrophy.
So what starts out as a temporary constriction driven by, hormones or nerves, eventually becomes a permanent structural narrowing of the pipe.
The pathology literally transitions from software to hardware.
That's a great way to put it. And to see how devastating just one of these mechanisms can be on its own, the sources bring up a condition called primary aldosteronism, or Conn's syndrome.
Oh, this is such a fascinating proof of concept.
Right. It happens when an adenoma, basically a benign tumor on the adrenal gland, just starts autonomously pumping out massive amounts of aldosterone, completely ignoring the normal RAS feedback loop.
And that excessive aldosterone drives unchecked sodium retention and, of course, severe hypertension.
But the crazy part is, if a surgeon just goes in and removes that tumor, removing the source of the aldosterone, the hypertension is often completely cured.
Right. It isolates just how immensely powerful that specific neuroendocrine pathway really is.
But that's a rare case, right? Like a precise anatomical fix. For the vast majority of people with essential hypertension, where all these systems are just subtly miscalibrated, treating it is highly complex.
Very complex. Which brings us right into the fierce debates that kind of define modern cardiology.
Let's dive into those. Starting with that 2017 threshold change we mentioned earlier, the controversial drop down to 130/80.
Right. The major catalyst for that policy shift was the SPRINT trial.
Okay, what did they do?
The researchers took adults with high cardiovascular risk and aggressively pushed their medications to drive their systolic pressure below 120. They compared that to a standard target group aimed at 140.
And the clinical outcomes were staggering, right?
Unbelievable. The intensive treatment arm had a 25% reduction in major cardiovascular events.
Wow.
The data was so overwhelmingly in favor of lowering the pressure that they actually halted the trial early. They decided it was unethical to keep the control group at the higher target.
So proponents of the 1380 threshold point to SPRINT and say, look, this is definitive proof that lower is always better.
Exactly.
There's always a but.
Right. Implementing that on a population scale brings some serious collateral damage, because by lowering the diagnostic line to 1 of 30, you instantly categorize nearly half of the adult U.S. population as hypertensive.
Which critics argue invites massive overdiagnosis.
Yes. You risk putting millions of patients, especially the elderly, on these really aggressive pill regimens, and the side effects like orthostatic hypotension, which causes dizziness and falls, or even acute kidney injury, those might outweigh the theoretical benefits.
It's that classic tension in public health, isn't it?
Right.
Optimizing care for the individual versus setting broad rules for the whole population.
Absolutely. And that exact same tension shows up in probably the most deeply entrenched debate in this whole field, the role of dietary salt.
Ah, yes, the salt controversy. For decades, public health messaging relied heavily on epidemiological studies like InterSalt from 1988, right? Where they surveyed 52 populations globally.
Right, and InterSalt famously highlighted groups like the Yanomami tribe down in the Amazon basin.
And what's their deal?
Well, the Yanomami consume virtually zero processed sodium, and hypertension is practically non-existent in their society, even in their older folks.
So the immediate public health takeaway was this super blunt directive. Salt is the ultimate villain. It drives hypertension for everyone.
But extrapolating data from the Yanomami to modern urban populations is scientifically perilous.
Because they live a completely different metabolic existence.
Completely. They have no obesity, they're incredibly physically active, and crucially, their diet is packed with potassium from unrefined plants. The ratio of potassium to sodium is vastly different than ours.
That makes sense.
And if you actually look closely at the InterSalt data across the other populations they studied, the linear relationship between salt and blood pressure was really variable, often statistically weak.
Which brings up the physiological reality of salt sensitivity. Because telling everyone to universally restrict sodium kind of ignores the fact that renal handling of sodium is super individualized.
Right. If Guyton's theory holds up, some people have kidneys that can effortlessly excrete a ton of sodium without needing a spike in blood pressure to do it.
But others aren't so lucky.
Exactly. Other demographics, particularly older adults and Black Americans, often show profound salt sensitivity.
Why is that? What's the mechanism?
Well, in salt-sensitive folks, you often see a state of low renin hypertension. Their baseline RAAS activity is already dialed way down because their bodies are holding on to fluid.
Okay.
So when they eat extra dietary sodium, their kidneys have virtually no physiological room to downregulate renin any further to dump that sodium.
Ah. So the only tool the body has left to force the sodium out is a massive, dangerous spike in systemic blood pressure.
Precisely. So telling the entire population, hey, just eat less salt, is using a really blunt policy instrument to manage a highly nuanced genetic variable.
Wow. Okay, there's one more major controversy we have to unpack. The battle over which system is truly the master regulator. Guyton's kidney theory versus the sympathetic nervous system.
Oh, this one is a wild story. This debate manifested in a literal billion-dollar clinical drama around a procedure called renal denervation.
Okay, set the scene. What was the theory?
So the nervous system advocates theorized that if you could sever the overactive sympathetic nerves that wrap around the renal arteries, you could silence the signaling that tells the kidneys to retain sodium and release renin.
Basically severing the fight or flight connection to the kidney.
Exactly. They thought it would effectively cure hypertension. The procedure involves threading a catheter into the renal artery and using radiofrequency energy to burn or ablate those nerve fibers.
And did it work?
Well, the early unblinded trial showed massive, sustained drops in blood pressure. The medical device industry went crazy and invested heavily.
But then came the Simplicity HTN-3 trial in 2014, and they introduced a crucial scientific control, a sham surgery group.
Yep. Patients in the control arm were sedated, they underwent the catheter insertion, but the radiofrequency energy was never actually delivered.
It was a surgical placebo.
Literally a surgical placebo. And when they finally unblinded the trial, the results were sobering.
What happened?
The renal denervation group showed absolutely no statistically significant reduction in blood pressure compared to the sham surgery group.
That is, wow. It's this legendary cautionary tale about the staggering power of the placebo effect, even in hard physiological metrics like blood pressure.
Yeah, and it underscores just how resilient and redundant the body's compensatory mechanisms truly are. If you burn away one pathway, the interconnected systems just adapt and maintain the high pressure anyway.
Which is terrifying. So, for you listening, how does this silent biological civil war actually manifest in your daily life?
Well, the most dangerous misconception is that you can actually feel it happening. People assume that, a headache or facial flushing means their pressure is spiking.
Right, but unless you're in a hypertensive emergency where your organs are actively taking damage, the pathology is completely asymptomatic. You cannot feel the sheer stress on your endothelium.
Exactly. This is why consistent screening is just so imperative.
But even clinical screening is tricky, right? Because of things like white coat hypertension.
Oh, definitely. White coat hypertension is when just the anxiety of being in a doctor's office triggers your sympathetic nervous system, giving you an artificially high reading.
But the sources say the more insidious variant is actually masked hypertension.
Yeah, masked hypertension is dangerous. This is where your readings at the doctor's office are perfectly normal, but your ambulatory or home readings, like during the stress of your workday, are persistently high.
And if that masked hypertension goes undetected, the downstream consequences are severe. The sources basically describe hypertension as the central node in this dense web of vascular disease.
Let's trace that out. Let's look at how this mechanical force drives other pathologies.
Starting with the vessels themselves, right? That sustained high pressure acts like a sandblaster on the delicate endothelium.
Yeah, it causes mechanical injury. And that compromises the endothelial barrier, allowing LDL low-density lipoproteins, or cholesterol, to penetrate the inner layer of the artery.
And then the immune system gets involved.
Right. Macrophages show up, they consume the lipids, and it triggers this whole inflammatory cascade that results in atherosclerotic plaque formation.
So hypertension doesn't just narrow the vessels by constricting them, it actively accelerates the physical blockages of atherosclerosis.
Exactly. And then we have to look at the pump itself, the heart. Because the left ventricle is constantly pushing against that heavy peripheral resistance, the heart muscle physically remodels and thickens.
Left ventricular hypertrophy.
Yes. And while it starts out as an adaptive response, building muscle to handle the heavy load, a thicker heart wall is a stiffer heart wall.
Which leads to a really specific type of heart failure, right? Heart failure with preserved ejection fraction, or HFpEF.
Yep, HFpEF. The heart muscle gets so thick and rigid that the actual volume of the ventricular chamber shrinks down.
So the tank is smaller.
Exactly. The heart still pumps out a normal percentage of the blood inside it, which is why they call it preserved ejection fraction. But because the absolute volume it can hold is so tiny, the total cardiac output falls way behind what the body actually needs.
That sounds awful. And perhaps the most destructive feedback loop of all occurs in the kidneys. The high mechanical pressure physically damages the delicate nephrons and glomeruli that do the filtering.
And tying it back to Guyton's theory, as those nephrons die off, the kidney's capacity to excrete sodium just plummets.
Which expands the blood volume, driving the systemic pressure even higher, which in turn destroys even more nephrons.
It is a devastating bidirectional cycle. Chronic kidney disease exacerbates hypertension, and hypertension accelerates chronic kidney disease.
It really is a sobering cascade of cellular damage. But to bring this back to the practical application for you listening, this deep understanding of the pathophysiology completely changes how we view that boring lifestyle advice we joked about at the start.
Oh, completely.
When your doctor recommends dietary changes or exercise, they aren't just offering generic wellness tips. They are prescribing precision physiological interventions.
Right. Every single lifestyle modification maps directly onto the four mechanisms we've been talking about. Take weight reduction, for instance.
Okay, how does that work mechanically?
Well, adipose tissue body fat is hormonally active. So reducing it directly decreases sympathetic nervous system hyperactivation. It improves insulin sensitivity. It fundamentally turns down the fight or flight signaling that constricts your vasculature.
Wow. And it makes perfect sense why the dietary approaches to stop hypertension is so incredibly effective, too.
Absolutely.
If Guyton's theory is right, and the kidneys are struggling to maintain sodium balance, the DASH diet swoops in by introducing massive amounts of dietary potassium right alongside sodium reduction.
And that specific mineral ratio forces the kidneys to recalibrate their filtration parameters. It literally eases the pressure natriuresis curve.
The clinical data from the 90s even showed that strict adherence to the DAH diet could lower blood pressure as effectively as a pharmaceutical drug in some demographics.
That's powerful stuff. Similarly, aerobic exercise induces sustained shear stress that actually stimulates the endothelium to upregulate nitric oxide synthase.
So it chemically forces the blood vessels to relax and dilate.
Exactly.
And the pharmacological tools that cardiologists use, the actual pills, they're designed to intervene in these exact same pathways. We aren't just throwing random chemicals at the wall.
No, it's very targeted, like ACE inhibitors. They chemically block that convergent enzyme in the lungs, instantly stopping the production of angiotensin II and dismantling the RAAS cascade.
And beta blockers.
They bind competitively to the adrenergic receptors on the heart and the blood vessels. They physically block epinephrine from attaching, which blunts the sympathetic nervous system's ability to drive up your heart rate and resistance.
And then you've got calcium channel blockers, which literally prevent calcium ions from entering the smooth muscle cells of the arterial walls, so they mechanically prevent the muscle from contracting and narrowing the pipe.
The pharmacology is just a direct mirror image of the pathophysiology.
It really is. So, to synthesize the ground we've covered today, we started with brass pipes and conscious horses and navigated through this continuous biological risk gradient.
We tracked how medical consensus evolved from thinking high pressure was a helpful adaptation for aging to recognizing it as a primary driver of cardiovascular mortality.
We mapped out the interlocking architecture of the RAAS cascade, the sympathetic nervous system, endothelial dysfunction, and the overarching mastery of the kidney.
And we waded into those messy complexities of population health policies, salt sensitivity, and the very sobering reality of clinical trials like Simplicity.
The overarching takeaway here is that essential hypertension is not some sudden binary failure of the system. It is a gradual, accumulating pressure that exploits the body's own regulatory mechanisms. It eventually turns our intrinsic survival pathways against our long-term health.
It is the ultimate example of a physiological adaptation becoming pathological over time.
Well said. Which brings me to a final thought I want to leave you with today. Earlier, we unpacked that phenomenon of baroreceptor resetting.
Right, the alarm system turning itself off.
Exactly. The reality that your body's vital pressure sensors will literally recalibrate to accept a chronically dangerous state as the new baseline normal. The body just stops fighting the high pressure because it's been present for so long.
It's a brilliant, but ultimately flawed adaptation.
Right. And it makes you wonder, if our internal biological alarm systems can be so easily reprogrammed by prolonged exposure to physical stress, what other unhealthy physiological, environmental, or even mental states is your body quietly accepting as normal right now, simply because you've carried the pressure for so long?
That is a profoundly important question to reflect on.
Thank you for joining us on this deep dive into the silent pressure. Take care of yourselves, and we will catch you next time.